I'd like to just try to explain to you what the aim of what we're actually doing this evening. What we're going to try and do is demonstrate to you how fundamental anatomy and basic surgical skills are to surgical training. We're going to show you how surgical skills are developed in simulation of varying degrees of complexity. And we're going to demonstrate to you how advances in technology have changed the way that surgeons are trained and the way that we practice today. And when we finish speaking, there'll be an opportunity for all of you to have an introduction to some of our interactive sessions, which you'll see all around the room, which we'll tell you a little bit more about later on. I want to emphasize how anatomy and basic surgical skills are fundamental to the whole of surgical training. So we start them at medical school, it's about 5 years usually. Then general training as any doctor, not just surgical doctors, any doctors have 2 years of training where they need to use surgical skills. For those who want to do surgery, we'll then have another 2 years of what we call core surgical training, where we do a variety of specialties. And then we decide to specialise in ENT or orthopaedics or urology, as the consultants you're seeing this evening. That takes another about 6 years. And then you're a consultant for about 30, essentially. But throughout all of that time, we're using anatomy. We're using anatomy every single day and our basic surgical skills. So the surgical teaching team this evening, who are going to take you on this journey through the training of a surgeon, are Professor Duncan Tennent, orthopaedic surgeon. We've got Robert Nagai from clinical skills and his colleague Jules, who will be speaking to us this evening. I'll tell you a little bit about our basic surgical skills training. And we've got our head of the GAP Centre here in the hospital, who works collaboratively with the medical school in this regard and simulation in surgical training. We've got one of my colleagues, hopefully, is going to arrive, one of the robotic surgeons. I think he's still in clinic. And Mr. Ayres will be telling us about robotics in urology. Okay. So, without further ado, Mr. Tennent.
Use the microphone. Right, so I get the sort of introductory bit, really. As Pippa said, anatomy is pretty fundamental to not just surgery, as you'd imagine, but the whole of medicine. You've got to know what's going on inside. And what's staggering is that people have been fascinated by anatomy for pretty well forever. Not entirely sure what's happening inside there, and they really want to know. And this picture, it's not exactly what we have these days. This is from 17th century, from Italy, and people used to sit in a massive auditorium to sit and watch the, not necessarily doctor, but anatomist demonstrating, crowds like this. Things didn't change much, and in fact, if anything, they got more popular. Looking at sort of the mid-19th century, people were competing. There were different schools of anatomy desperately trying to teach people because it brought in money. And you may recognise these two gentlemen at the bottom. And you may recognise the still from the film, Burke and Hare. Basically, things got so bad in Edinburgh around this time that there weren't enough bodies for all the people who wanted to learn anatomy in the different schools. So these enterprising gentlemen, first of all, started grave robbing, and then realised it was much easier to just knock people off, which worked quite well for a little while, but didn't entirely go to plan. And I don't think that Burke anticipated that he would end up being an anatomical specimen in the Royal College of Surgeons of Edinburgh. Now, things didn't actually change that much. But what did happen was people started writing books. And I thought I'd put this one up here. Henry Gray went to medical school at St George's and then became a clinical lecturer in anatomy here and produced this book, Gray's Anatomy, not the TV show. And that really became the sort of Bible for us, with beautifully illustrated pictures like this and reams of quite sort of poetic prose. And that was pretty well what we used, well, certainly when I was at medical school. Anatomy then became sort of the preserve, really, of the medical schools. People didn't go to public lectures to watch dissections anymore. And this is the sort of thing you'd have seen at the turn of the previous century. There's a crowd of medical students all sitting around a cadaver, book open, looking at the pictures, trying to work out what they were looking at. Things didn't change very much. It sort of kept on going. And this says 1936. I did my anatomy teaching in 1987, and it didn't look an awful lot different. Maybe the haircuts are a bit different, but we had the white coats, we had the book propped open with pictures, and we tried to work out what was going on. And that was pretty well it. Now, those of you who were around the turn of the century may remember these. Remember this? What's his name? Von Hagen, who created this thing, Bodyworks, where he did this amazing technique of plastinating human bodies and did stunning dissections. The thing there, that's the nervous system. Now, I never saw anything like that when I was at medical school. And there are loads of other ones. These are just sort of the nice ones that wouldn't scare anybody too much. And all of a sudden, anatomy turned around and became a public thing again. And the medical school sort of had to slightly up their game because they'd been left behind. And things have really, really moved on in the last 18 years. We get this sort of thing, which is available on the internet for you to look at, and we use it with the medical students. You can add layers to it, or strip layers away, turn things round, and little snippets that tell you what's going on. Then you get these sort of animations, and there's audio on these. There you go. And these are available on YouTube. You can actually now get a good look.
Is made up of 3 parts.
There you go, inside, and it zooms in, tells you all the bits you need to know.
Middle.
Okay, which really supports. Go on, go forwards. Thank you. And then there's this. This is the Royal College of Surgeons.
Now, the superior gluteal nerve is a very important nerve in that it supplies the gluteus medius and the gluteus minimus.
So we won't run through the whole thing, but there's this sort of thing that's now available. So you've got the traditional anatomy with the dissected body that you can look at the bits on. You've got computer-generated illustrations that you can see, and you've got somebody telling you all about it, and you can go backwards and forwards and spin it around. So anatomy is still important. It's vitally important. But there are so many different ways that we can now use technology to teach us what we need to know and go back for those of us who haven't done this for a while and revise it if we really need to. And where are we going? VR apps are starting to come in. The idea, you've all seen the sort of things on the films, that you can actually walk around the human body and you can turn it round and see it in real 3D. So all of these are available, things are changing all the time. I don't know where we're going to be, but what we do know is that we've got to know the anatomy. If you don't know the anatomy, you end up in all sorts of trouble. So I'm trying to set the scene for all the really clever things that you're going to get from everybody else later on. So I will hand over, and thank you very much.
Okay, so just to start by saying, sorry to disappoint, but I'm not a surgeon, but I do teach clinical skills upstairs, and so I think part of this discussion really is to see what we do very early on with our brand new budding students. So if I just, so I think everyone can recognise maybe a school leaver such as this, may not be able to make their own meals, may have never left home, may struggle to use a washing machine. And so certainly that was me at 17, just 18 when I went to university. So how do we get them to this? And in this picture, that's some robot-assisted surgery. It was actually a multi-national surgical team on a Navy ship. The US Navy. So can we get them from this to that, and how do we go through those steps? And so hopefully St George's plays a strong part in that, and how do we do it from the early steps? So when we think about surgery and we think about those early steps, those basic things, we think about practical skills. And certainly what we would expect a surgeon to develop are these high level of psychomotor learning, movement in conscious mental energy or activity. And then we think about these words like coordination, manipulation, dexterity. Some of these things are natural, but some of these things need to be sort of manipulated or supported or developed through some support from us. And then there's this connection between this interface between knowledge and action. Oh. Sorry if I can go back. Okay. So if you think about that, this is where clinical skills comes into play. So with these early budding surgeons. And what we use a lot of in St George's is active learning, so getting them in the lab, getting them to learn through practice, using the equipment, trying things out, and then also integrating some communication and knowledge as well. So the really important things they've learnt in their lectures, applying that in the surgical, in the surgical clinical skills sort of setup, and also communicating with actors sometimes, with patients, and with each other, and playing the role of a patient. It's very learner-centred. They're in a sort of supported environment where they learn in small groups, and therefore they can use those skills and apply those skills in a safe environment before they then meet the patients and are let loose on their own. So in terms of a sort of generalised principle, we've got these sort of 3 steps. We want our students to develop procedural knowledge. They need to be able to know how to, but then there's also this important component with it, the why. Understanding the basic science knowledge and, as introduced in terms of the anatomy, absolutely essential for linking those 2 together, but also adding a third component in terms of what the findings may mean, this clinical reasoning. And as much as that seems sort of a pragmatic, sort of straightforward approach, that's quite difficult for, as I said, the beginnings of these new students who might not be able to cook a meal. How are we going to get them to sort of get onto that journey and apply these 3 things? So this is when we use a lot in St George's, this idea of spiral learning. In the early years, there's the focus on the procedural skill, just the how-to, and maybe applying what they learn in terms of their lectures, their basic sciences. And thanks to this lovely picture from the Vatican, if you like, they're on the first sort of rungs down here. But in later years, during their 5-year process with us, integrating those skills, so using that procedural knowledge, but also learning the how, the why, and using the what would you do next in difficult scenarios, or developing different styles of doing things, or thinking outside the box in terms of using those skills. So as a sort of introduction to what we do in terms of clinical skills and how we get these brand new learners and school leavers in the whole, although we do have graduates, to then stepping towards these budding amazing surgeons, I suppose we'd like to think of it in terms of achievable small steps. And I think this picture sort of illustrates a lot of our students are sort of working their way up, and then hopefully are enthusiastic and promoted to then go that bit further and become a surgeon. Okay.
Okay, we're now going to talk about the next stage of the development of our surgical skills. So we now jump to year 4 of the medical student programme, and in year 4 all of our medical students will have an entire day devoted to the development of basic surgical skills. All young doctors need to be able to tie knots, whether they want to do psychiatry or chemical pathology or whatever, they still need to be able to tie knots. So we have a Royal College course that we do for every single student that comes through the programme. They learn to tie knots with hands, which you might think is like a bit odd, but there are different ways of tying knots. You can do it with instruments or with your hands. They learn to tie knots at depth, which is sometimes important in surgical practice. We get them to remove a skin lesion. They're able to remove lumps, and we do 4 different sorts of suturing. And this is a picture of them in the lab doing that. It's really, really important that all students and young doctors have a very, very safe technique for tying knots. Otherwise things fall out, drains fall out and things like that. We have a very structured way of doing it. The students will watch how to do it on the DVD, and then they will all learn at their own pace over the course of an 8-hour period. So they develop, sometimes they have to develop their own way of doing things, but this is the time where we have a one-to-one with them and give them personalised feedback. Some of you I know here are in lower 6 thinking about going to medical school. Think about transferable skills that you may have. Certain hobbies that you may have may be useful, for example sailing, mountaineering, very natural skills for knotting, even tying your own shoelaces. We do have students who can't tie their shoelaces, so we have to actually teach them in year 4. Now we make fake lesions in all sorts of funny ways. We use pieces of pig skin really, and we obviously have other things if students aren't happy with that, but we use pig skin and we make fake lesions with grapes. You can also make fake pus with toothpaste or hair conditioner, which smells a bit nicer than pus generally, but we always use proper surgical instruments, proper sharps, and knowledge of sharp safety is extremely important. We've been doing this for many, many years now, and we have shown that if you have a formal training in surgical skills as a medical student, you're much more likely to choose surgery as a career, because everybody actually needs these basic skills. You may wonder how we actually assess them. There are formal courses. The undergraduates have to be formally assessed in how they can tie knots, as do the postgraduate doctors. And you might be surprised to learn that there are 18 ways that you can do it incorrectly. And we have to actually pass the junior doctors as safe and competent in these processes. But obviously, as we get more senior through the training, there are external national and international examinations as well. So I'm now just going to pass on to my colleague from Nick, who we are very, very grateful to have Nick with us this evening, who is the head of our simulation centre in the hospital, and the medical students are very lucky to be able to work and enjoy time in his unit.
Thank you very much, Philippa. The Simulation and Skills Centre, which works collaboratively with the university and trust, essentially continuing the learning process around patient safety, around clinical skills and team working, etc. We do that in three ways. We use high and low fidelity simulation. I'll explain a little bit about that. Do a lot of part task skills, practice and training, and have forum and seminar events. Now, how do I move forward? So we have a purpose-built centre that basically sits around three laboratories. A skills laboratory, which can accommodate about sort of 25 to 30 people having a hands-on practice skill station. Simulation laboratories, which I'll show you. We have two of those with one-way mirrors that come across. So the blue line is a one-way mirror that people can observe their colleagues, and it's peer observation we're really looking at. So here are the laboratories. They contain everything that a normal clinical environment would have: the same fascia, the same notes, the same electronic data, X-rays, the same monitors, fluids, drugs, everything. The only difference is that the patient is not a real patient, although we're starting to learn from the university and use simulated patients, actors, which is really terrifying. So we have two of these laboratories. We have a control room where the clever people will sit and look through the one-way mirror, controlling perhaps the physiology, monitoring the cameras in order to give feedback, and then another one-way mirror which the peers sit through and observe. So that's what you'd see if you were sitting and observing your peer group. You could have more data up here. This is a theatre team that are having a team brief prior to surgery. The physiology is up here, and the rest of the group sit around this table with some observation sheets looking at perhaps clinical acumen, knowledge of a clinical situation, as well as non-technical skills, communication, decision making, leadership, etc. And a camera on the top, and that's quite important because that plays a role in giving feedback, and they can play the video back and show best practice. Now our robots, since this is about sort of high technology, are pretty good. They're not $5.5 million like a flight simulator, but they are $420,000 each. They have gaseous exchange, they breathe, they blink, they urinate, they bleed. They have some perhaps not so clever technology, infrared bar scanner near the cannula, so it knows what drug is given, it knows how much, and how quickly that drug is given. So for instance, if we wanted to pressure a junior doctor into to giving morphine to a patient, to a 7-year-old boy, and the mother is demanding pain-free for her 7-year-old boy, they could give too much morphine too quickly, and the computer modeling system of these simulators will stop the breathing automatically, or slow it down. So it's completely physiologically independent. It breathes in and analyzes the gas content, etc. This would be a typical sort of setup for an intensive care for pediatrics, perhaps. We use this on organ donation training. But really what we are interested in is looking at the real team, the behavior between healthcare professionals, the leadership, where that sits. We involve everybody, medical students, healthcare professionals, etc. This is probably one of the most challenging courses that we've run, which is for cardiac surgeons, which is a bit of an oxymoron to talk about communication and non-technical skills with cardiac surgeons, with perhaps the God complex that they have. But it's very interesting. We had to put together 7 different simulators to make this work. So we had a beating heart simulator. We had a human patient simulator on the table, a transesophageal simulator, and a heart-lung bypass machine simulator. And this is the real heart-lung bypass machine that came up from theatres. And again, that's a view from the observation room. We also take our surgical trainers and mannequins outside and into the environment. So we mix it with the clinical environment and the clinical teams. And here you can see that we're operating in intensive care, in neuro-intensive care. This is the operating theatres where we run major hemorrhaging scenarios, birthing, and this is a mannequin going out with a practice nurse educator. So all the technology can be fixed and mobile and used in the clinical environment. Now, so this is interesting. I think we have a robotic surgeon who's going to talk to us about this system. But we took our simulator into that system to check its integration and whether or not we could undock the patient during the middle of surgery, in robotic surgery. So we had to design our own simulator to fit in with this and run it as if it was a real patient. So we're probing the system constantly, testing the policy and procedures. This is in the CT scanner, the bottom 2 photographs, and just checking their emergency response to when a patient perhaps has a cardiac arrest in the middle of a scan. We also take it further afield, worked with the fire service, with London Fire Brigade, rescuing patients, having road traffic accidents, and again treating cardiac arrests. We've got some toys here for you to play. The clinical skills training, as Pippa said, still is continually reinforced around the basics. Basic surgical skills and perfecting those over the years. But the technology has moved on a bit. We now integrate a lot of technology to enhance that learning and teaching process. So it may be that we just have one expert teacher here with a camera above it that's printed out across all the monitors around the room. Or we go into theatres and beam the pictures straight out of theatres to another room like this, where everybody can sit and observe and discuss the case with the surgeon. Our mannequins are getting cleverer and cleverer. This is a transesophageal echo simulator that looks at the heart and can look at the blood pumping through the heart. It's about 120,000 pounds. But before we use that, we will get to do some basics on a pig heart. Get to dissect it, make sure they know the anatomy, etc. to reinforce that. You're going to be taking part in this. This is laparoscopic keyhole surgery. We have 2 of these machines here for you to play with, and then we have the virtual reality. Very clever machine. You can see a gallbladder. We can take a gallbladder out, but when you touch it, you can feel it. You can pull on a vessel. So it has something we call haptic feedback. And it also tells us your economy of movement, left and right hand, etc. You're never too young to start. These are some of the children we've had in widening participation events. So please get involved, come up and have a go, and we'll give you some feedback. There's much more information on our website, gapsimulation.com. Thank you very much.
Good afternoon, everyone, or good evening. Sorry, I'm a bit late for that. Come from clinic. I'm one of the ENT head and neck surgeons are here at St George's. Just a quick show of hands. How many of you are A-level students? So I know it's a picture. Okay, good, excellent. Thanks, Philippa, for the invitation. Now I've got about 10 minutes to talk about robotic surgery. So it's a lot to cram into a very short space of time. And I think hopefully this can show how you go from the fantastic sort of basic skills and simulation into clinical practice. So you'll kind of know what a robot is, in case for those of you who are wondering. It's basically it's a machine that can perform a complex task automatically. So when you think of robots, the actual definition of a robot was first used by a Czech playwright, for those of you who are very cultured. Some of you probably know this already, I presume. Probably, okay, you've learned something new today. So 1921, Czech playwright, he produced this play, and that's where the word robot was first used, and it was basically around laborers. And when you think of robots, most of you think of Star Wars, I presume, or Transformers. I had to put this in because my kids said, you've got to put something that's a bit more relevant for the youngsters these days, okay? Or for the older people in the audience, you might have seen this, okay? iRobot, that's, some of you are shaking your head, so it's for the older ones. So when you think robot, you kind of think of a machine that's it starts off doing what you tell it to do, but then turns bad and takes over and does all kinds of horrible things. Well, thankfully, the current robots we use are actually master-slave systems, so they don't do things on their own. We tell them what to do, or we move things. There are one or two robots that are actually fully automated, but the ones that we currently use in clinical practice are master-slave systems. Now, I want to take you on a little bit of a journey, because what has happened is that surgery has evolved over the last, I would say, 3 to 4 decades, because historically, for hundreds of years, you did open surgery, where you would buy the patient, you made a cut, you had a feel, obviously with gloved hands. There used to be a time when they didn't wash their hands. We'll come back to that. But these days, we wash our hands, we gown up. And you get instant feedback from the patient. You can collaborate with your colleagues. That's the way to do things. But however, it's highly invasive. Ergonomically, it's challenging because you have to stand for long periods of time. And for patients actually do used to complain that it took a long time to recover. But it's a lot better than what you see here, which is an amputation 19th century style, no anesthetic. You just have to hold patients down. We have moved on a little bit from that. And this is kind of a modern day operating theatre in St George's. You can see lots of equipment, everyone's clean, gowned up. But still, despite the evolution, patients kind of want something better. So laparoscopic surgery came in, and what we do there is we do things through small incisions, keyhole surgery. You look on a screen, you operate your instruments. So patients used to go home quicker. So an operation where they would stay in hospital for 5 days, they go home after a day, and that significantly improved things. But that's only been going on really since the 80s. So where robotic surgery has revolutionized things is now you're not actually by the patient. You're actually sat remotely, usually in the same room, but you could be on the other side of the world operating. And here you have your surgeon on the console controlling all these instruments. And it's just gives you a contrast to what it's like with other current situations. So same surgeon, but this time not by the patient, operating the robotic console. So it has a lot of implications for situational awareness. You heard a lot about non-technical skills, being able to communicate with your colleagues, for instance, and this is where the robotics does raise a few challenges. So we talked about some of the benefits. Supposedly it's less invasive, patients go home quicker, less risk of infections, complications. Some of it is still being debated, but it's the direction of travel is that this is what we should be striving for. How do we achieve that? Because the robot, it allows you to do scaled movements, so you can move 5 times distance outside of the patient as you would inside the patient. You've got 3D vision, you've got wristed instruments, so my hand can only move in certain directions, but with the wristed instruments on the robot, you've got more degrees of freedom, as they call it. And for head and neck surgery, this is one reason why we would use the robot. So this is a patient, you all know what this is, just in case you're wondering. It's the mouth, not anywhere else. Okay, you're looking in the mouth, that's the uvula, the dangly bit for those of you who can see that. And this is a big tonsil cancer. So what we're seeing now, and we're seeing an increase, a rise in the incidence of tonsil cancers or tongue-based cancers in younger patients. So historically, we would normally treat them with radiotherapy, but radiotherapy has significant side effects, although it's a highly effective treatment. So the question is now being raised as to how else can we treat these patients. So one option is to cut this cancer out, but there are some very important structures in the region where we're operating. The carotid artery, which is taking all the blood from the heart towards the brain, for example, some very important nerves. So you do want to use the benefit of the robot with its magnification, its 3D vision, to be able to do the surgery more precisely, because historically this is what we had to do to take out that tonsil tumor. We had to make a big cut in the patient's lip. I was told I wasn't allowed to put gruesome pictures in case people passed out, so I had to take something from a textbook. Okay, so we had to cut the lip, cut the jaw open everything like a textbook, and then cut out the cancer. That's what we used to do. And yes, you've cured your patient of their cancer, but they're miserable afterwards because they can't swallow, they can't talk, and they can't do other things that they would like to do. So I'm not sure if this video will play, but this is an example now of the precision you can get using the robot. So it's a fantastic view. It almost feels as if I'm in the mouth, okay, or in the throat. I can see precisely where I need to cut. The carotid artery is kind of hiding in here, and I'm not as sort of nervous as I would have been if I was doing this just using a headlight. For instance, you have your assistant can give you more arms. So rather than just having 2 arms, you can actually have 4 arms. So there you are, surgeons operating the instruments. So you can be a lot more precise with your resection, essentially, okay? And then you can get the tumor out. That's a horrible looking tumor. And if we just get to give you some idea of what it's like, okay, probably should turn this down. Okay, let's turn the volume down a bit, just in case someone's swearing. But this just gives you the view outside of the patient, so you can see the instruments in action. So this is all going through the patient's mouth, and I know you think, oh, this all looks a bit horrible, you know, a machine that can make a small car, fitting it through the patient's mouth. So that's your surgeon there, kind of immersed in their own world, but the view on the screen that everyone can see is what your surgeon can see. So that's the robot in action. So just to give you some idea of where we've come from, this is all relatively new. The urologist tried a robot for prostate surgery back in the 90s, and it has all kind of evolved into a sort of a fully automated robot for doing hip replacements to the current robots that we have now. But this has only been going on for the past sort of 20 odd years. It's a bit like the mobile phone, okay? Some of you probably don't recognize the stuff on that side, okay? You're only familiar with the iPhone. But it started off as a brick, as we call it, and things are evolving. And likewise, robots will continue to evolve. And I think Ben Ayres will give us a nice lecture later on the evolution or where we're going. And this all came about. The robot actually came about because of the U.S. military. As you know, the U.S. like to spend a lot of money on defense. They're working towards having fully sort of automated robots that can go and do all their work for them. But until they get to this Terminator stage, they had to think about how can we sort of get our soldiers treated without sending all our surgeons into the battlefield. So something like this was what they kind of thought about, but that didn't quite work. But the idea is that if you had a surgeon in America, they could be operating on the patient in the battlefield somewhere in Iraq. So that's where the initial ideas for robotic surgery came from. And consequently, you can see how the Americans have got, you know, more robots than anyone else in the world. Over almost 3,000 in the USA, but only a handful in Europe and everywhere else. So in summary, this was really just to give you a flavor of what robotic surgery can do. It's a new way of operating. It does raise a few questions about, you know, situational awareness, the team working as well. But I think it's exciting direction of travel. There is a big debate about cost effectiveness because, as you know, we work in an NHS system where we're forever running out of money, and the additional expense of the robot is something we have to question. But I think overall it's a good thing. Okay, thank you very much.
Good evening. My name is Ben Ayres. I'm one of the urological surgeons in this hospital, and I'm going to talk a bit about robotics in urology. A lot of the information about robotics we've just heard about, but I'm going to take you back a little bit further. So keyhole surgery, which a lot of people think of as initially laparoscopic surgery, actually started back in 1878. That was, we started using cystoscopes to look inside the bladder. So urologists have been at the forefront of using technology and trying to minimize the cuts and the scars on our patients for a long, long time. The picture you can see on the side of the screen is an interesting picture inside somebody's bladder. Not entirely normal. That's a bladder with some infection and some inflammation and some swelling in it. So in 1878, cystoscopies were developed, and I suppose as urologists, we were fortunate that we could get inside the bladder through a natural orifice. Keyhole surgery then started taking off in the 1980s. The first laparoscopic appendicectomy, so removal of appendix, was done in 1982. The first removal of a gallbladder was done in 1987. And then the first keyhole surgery in urology using the laparoscopic system was removing a kidney, and that was done in the United States in 1991. And then soon after that, we used keyhole surgery to remove the prostate for prostate cancer. Robots then started to take over. You've heard a bit about the Probot. This was a machine that was designed to be automated. So it was a machine designed to cut out the middle of the prostate to relieve the obstruction that an enlarged prostate can sometimes cause on passing urine. So the prostate sits underneath the bladder, and if it gets big, as it does in a lot of men as we get older, it can obstruct urinary flow. And one of the ways we treat that is with the cystoscope. We go through the water pipe and we cut it away, and somebody developed an automated machine to do that. So they set it on autopilot and sort of walked off. That hasn't taken off, you'd be pleased to hear. There were problems with bleeding and controlling the bleeding, and I'm pleased to say that surgeons still have a role to play in surgery. So this hasn't taken off, but perhaps it is a sign of what might happen in the future. Automated surgery may be something that's there in the future. So the Probot was the first attempt at robotics. And then a robotic arm came out in 1993 that would hold your camera. So when you were doing keyhole surgery, rather than having an assistant holding the camera and moving it around to show you what you wanted to look at, a robotic arm would hold it. And by moving your head left or right, the camera would move left and right. So it reduced the need for assistance and kept the camera nice and steady. So robotic arms came in. And then, as we've heard, the USA tried to develop robotic surgeons for the battlefield. They wanted to reduce the risk to their surgeons in the battlefield and have them sat in the States on machines and doing the operating remotely. And that's where modern robotic surgery has been developed from. And a lot of the technology that we're using nowadays was expensively developed by the American Defense Department. I think they realized that, unfortunately, to fit the patient onto the robot, you still needed people to take the patient away from the battlefield and back to an operating theatre. I think originally they had designs of the robot being on the battlefield actually doing the operating. So it didn't quite take off. But as you've seen pictures, the modern day robotic surgery is a remote tool. The surgeon does not need to be sat in the same room as the robot. We do that because often we want to be there and we want to have that situational awareness. But there have been operations done with a surgeon sitting in Paris and the patient in the United States. I believe the French Telecom put extra cables under the Atlantic Ocean to make sure the stunt went off without any problems. But surgery can be done technically at that distance. The first use of the robot in urology surgery was removing somebody's prostate, and that was a robotic assisted radical prostatectomy done in Paris in 2000 using this Da Vinci robot, as you see on the picture. And in urology it took off really quickly, particularly with the prostate, and I'll talk a bit about why it's taken off. But in 2014 2,500 robotic prostatectomies were done in England, and that was approaching about 70% of the prostatectomies done. I couldn't get any data for the last year, but I know that very few prostatectomies are now done in this country other than by the robotic means. So it's probably approaching somewhere around 5,000 a year now in the UK. It really has taken off in this country. So just to reiterate, the robot that we use nowadays with you sit in the seat with the control panel, and then the robotic arms are there doing the work. It's not automated, it is a slave. It does exactly as you as the surgeon tell it to do. Okay, so to operate this machine, you need to be a fully trained surgeon first. You need to do your medical school, you need to do your surgical and anatomical learning to be able to use this safely. It is not automated, so all that learning that you've heard about, all that simulation that you've heard about really comes into play here. But because it's highly computerized, not only can we do simulation by setting it up like we've got here. I think I've got a pointer. So not only can we set it up like we have here with a table underneath it and some sugar cubes or something that you might stack, because it's highly computerized, there's actual virtual reality built into this screen, so you don't actually need to set the robot up. You can sit there on this screen and start some simulation programs, a bit like the laparoscopic trainer over there with the gallbladder operation. So you can sit there and you can do your suturing, you can do your cutting, all on a simulated model, all on a virtual reality model. What are the benefits? We've heard about the benefits. First of all, smaller wounds. You go in through 8mm, 10mm holes rather than a big cut. And for urology, that's made a big difference because a lot of urology surgery is in the pelvis. And to access the bladder, to access the prostate in the pelvis, you have to make a big cut, which goes from at least the belly button down to the top of the pubic bone, if not from above the belly button. So you make big, painful cuts historically. Now with the robot, we make 8mm, 10mm cuts. So as a result of smaller wounds, you have less pain, you have less bleeding, and therefore the patient feels better at the end of the operation. It used to be that when patients used to have big bladder surgery, when they used to have their bladder removed for nasty bladder cancer and then have a bit of bowel put in its place, patients would lose a lot of blood, have blood transfusions, and after the operation they would be washed out. Nowadays, doing it robotically, at the end of a 6-7 hour operation, they wake up, they're sat out having a cup of tea an hour after the operation has finished. It's amazing how this minimally invasive surgery has transformed things. So it allows for less bleeding, less pain, and earlier mobilization. And mobilization is key to reducing complications. If you're up on your feet after surgery, you're less likely to get clots, you're less likely to get chest infections. So really important. You get better vision. As you can see, this is the eyepiece that you look down, and you've got one camera for each eye. So you get true 3D vision. It's proper 3D vision, and it's magnified. So everything is much clearer. You've got a bright light shining exactly where you want to see, and you have the camera placed exactly where you want to see. One of the problems of pelvic surgery, even though you make a big hole if you do it open surgery to see the bladder is actually quite a long way inside the body. Even when you're trying to shine proper lights on and have a head torch on, you can't clearly get nice bright light on what you want to see, whereas with the robot you can, and you can be really precise with your surgery. So it really helps with the precision of surgery. And ergonomically, it's really good. So you've got the full range of movement of your wrist. As you can see here, these are the robot arms. We're tying a knot, and we've got the suture looping around the instrument, and we will then be pulling the suture through. And you can only do this easily if the robotic arm moves like your wrist. And as you can see there, it's at about 70 degrees, isn't it? It's bent, it's moving like a wrist. Historical keyhole surgery using straight instruments was a bit like using a pair of chopsticks. And we all know what trying to eat food with chopsticks is like rather than using a knife and fork. It's much harder because everything's straight and doesn't move so easily. And that was the same thing. Trying to stitch with straight instruments meant your arms got in all sorts of funny angles, whereas with the robot you've got this wristed technology. And as a surgeon you're sitting down, so it takes a lot of the strain off your shoulders and your back. So some of the procedures that we do in urology. So first of all, I've talked a lot about prostatectomy. So we remove the prostate if somebody has prostate cancer, or it's one of the options for treating prostate cancer. There are other options. And this is a diagram, that's the bladder. This is the prostate sitting here underneath the bladder. And that there is the muscle, this shaded area is the muscle that keeps you dry. So you can see if you're removing this prostate, you're coming very close to the muscle that keeps us dry, the sphincter. You're operating very close to that, and all the nerves that supply it run all down the side of the prostate. And therefore being precise, having good vision of that area makes it much easier to spare nerves, makes it much easier to put stitches to join this area back to this area after you've removed the prostate, and therefore functionally patients get better outcomes. They leak urine for less period of time after robotic surgery than the traditional open surgery. It really helps with functional recovery. We also use it a lot in kidney surgery. This is a picture, a cartoon of a kidney with a small cancer on it. Now, traditionally, this would have either been a big open cut across the whole side to get to that area to remove just the lump. Or if you were doing this with traditional keyhole surgery, you might be more likely to take the whole kidney out, because trying to cut just the lump out and then stitch it closed again is very challenging with those straight instruments. Although it was possible, it was very challenging. And the main problem with that is you don't want it to bleed as you're operating on it, so you've put a big clamp across the main blood vessel to the kidney. If you've got a clamp across the blood vessel to the kidney, it's not getting a decent blood supply, and after about 20 minutes, the organ will no longer work. So you've got a 20-minute period to cut the lump out and stitch it all closed, which with traditional keyhole surgery is very challenging. Again, with the robot, with the good vision, with the wristed movement, you can do this operation more straightforwardly. I wouldn't say it's necessarily easy. It still involves a lot of skill and a lot of learning, but it is more straightforward. And then again, you can remove just the lump. You don't have to remove the whole kidney. You're saving most of the patient's kidney, and you're doing it through a small, less painful scar. Cystectomy, this is a big operation. As I've said, this is a 6-7 hour operation, and it means removing the whole bladder for bladder cancer, and then using some of the bowel to create either a new pouch for the urine to drain into, or a straight bit of bowel for the urine to drain out of. And all that handling of the bowel, all that reconstruction of the bowel requires a lot of suturing. So again, using traditional keyhole methods, this just was too challenging, too difficult, and ended up with big cuts. Now with the robot, we can do this all completely through small cuts, because we've got good vision, we've got ease of suturing, and again, we can spare nerves and help with the continence mechanism afterwards if we're building a pouch. And that's just an example of, this is a bit of the bowel being cut and got ready to make a new pouch. And the final procedure that we use the robot a lot in urology, again, is a kidney procedure, but this time it's not a cancerous one. This is to do an operation called a pyeloplasty. So some people are born with a slightly dysfunctional drainage tube of the kidney. And what happens is that instead of draining freely through this area, it dilates up because there's a bit of narrowing there. And so you can do an operation where you sort of cut there and you cut here and you stitch it all back together, so you end up with a much thinner, more anatomically normal drainage tube to drain. Again, involves a lot of stitching. And again, trying to do this through traditional keyhole methods is challenging. So again, often would involve either a very challenging keyhole operation or a big cut. Again, nowadays with robotics, people can have this operation through small cuts. And this is an operation that often is done in younger people. People realise they have this developmental problem with the kidney often as teenagers, so they're very active people, and you don't want them to be inactive due to big cuts. So again, the robot has really transformed surgery in this field. So robotics have been are used extensively in urology, particularly in cancer surgery, but also non-cancer surgery, as I've shown there. Urology is one of the specialties that has really embraced robotics, I think, because of a lot of our operating is in the pelvis, where views aren't as good with open surgery, and also because a lot of reconstruction and suturing is needed, and the robot really has helped with that. We've talked about the advantages of early mobilization, great vision, and easier suturing. Well, what does the future hold? I think we've already got technology that can fuse our CT scans, our radiology imaging, over normal anatomy. So you could sit at the console, you could be saying, now where is that lump in the kidney I need to remove, and you hit a button and the CT scan appears directly over the kidney you're looking at, and so you can pinpoint where the lump is that you need to remove. So that technology is already here. It's not in widespread use because it's being developed, but it's already here. Virtual reality. Robots starting to learn some of the basics, some of the maneuvers. You know, is there a role for artificial and automation? I think probably there will be one day, but not just yet. Thank you.
Okay, thank you so much to our lovely speakers, and we've learned a great deal about the surgical journey there this evening, so thank you. And now it's time for you to enjoy the interactive sessions that we have. All of our speakers here this evening are most happy to take any questions that you may have, so just ask any of us. We'll be very happy to answer them, and if we don't know the answer, I'm sure we'll know someone who can help you. Around the periphery of the room here, we have a variety of things that we'd like you all to have experience of. There's the T, obviously there. And we've got anatomical models here with Joe and the anatomy team over in this corner here. At the back, we've got Harry and the medical students who are the team going to, if anybody would like to learn how to tie a surgical knot, we've got some low fidelity simulation over there. And in the corner, we've got Robert and the clinical skills team. If you'd like to have a go at intubating a patient, see if you can get any air into the lungs. That's quite a fun thing to try and do. And then we get we have got the high fidelity simulation over here with the laparoscopic trainers and the simulated model over there. So I'd like you all to enjoy all of it. Well, we'll give you a call at sort of 7:15 to say, you know, there's a quarter of an hour left, perhaps you might like to move on. But if you're enjoying something, obviously, you stay there. And just for the sixth formers here, just before you leave, there is a document that's produced by the Royal College of Surgeons, which has just got some useful information if you're thinking about going to medical school. It's got some useful information. And I think Julian just wanted to say a quick word before we...
Well, wow, what a series of talks. I don't know about you, I want to be a surgeon now, or at least go and have some surgery. I think it's been a fantastic illustration by all of our speakers about how medicine moves with the times, and how this is really, technology driven. It's just fantastic. I feel I do need to say something in defense of chopsticks, though. Although I don't think I could remove a tonsil with chopsticks, so perhaps we'll just have a conversation later. I noticed that during Ellie's talks, not many people were having the cakes, but please go and finish off the food. Now, I did say at the... anybody who's interested in learning more about some of the topics we've talked about here today, here's a couple of websites. One is the Royal College of Surgeons, and if anybody's interested in coming to study medicine and learning and using some of these skills here, you can find out more about our courses in medicine at St George's. So at the start of the evening, I did say that this was the last spotlight of the academic year. We've had a great year. There have been 6 events. I'm afraid we had to cancel 1. And I know that many of you have been to most of these, actually. We do really appreciate your feedback, though, because it is about public engagement, and we do want to know what we're doing right and what we're doing wrong. So please tell us, because we're at the moment designing the agenda for next year. But I can already tell you that the first spotlight next year will be on the 18th of October, and it will be presented by Dr. Caroline Copeland, one of our early career researchers, and she's going to be talking about this fascinating topic of study drugs, trick or treat. So that's just before Halloween. So please, if you can join us, you'd be very welcome to come. So let's go and have a go and enjoy the rest of the evening. Thank you for coming tonight.
Clinical teachers, nurses, they can be physicians, they can be surgeons, and they're interested in using simulations as one of the educational strategies. This is a wide range of strategies to deliver education. This is just one branch of it. You can go out and do it.
So if you let me come closer in here. What you'll be able to see on the model. What I would like to see is breathing well, whether the air is going in the wrong place. Now if you look inside,
I don't know what you were doing. The middle finger, almost.
Very good.
Have a go trying the second. Yes. Perfect. Okay. Excellent.
Back and play better now, so there we go. See, he's blinking now. If you put your hand on his chest, you'll feel his lungs moving. So you feel the...
Yeah. Do you want to? You might want to resuscitate this patient. We've got the gallbladder off, but I'm not sure we clipped the cystic ductal artery prior to taking the gallbladder off. Yes, so we might want to do some quick.
You might want to quick look and see where you're going. Yeah, there it is. Now you go. So I put it, drop it in, I'll put it in this one. Gently does it, that's it. Follow it in so you don't follow the screen. Yeah. You get a bit of perspective.
So at the moment, Dan was taking some time in summer to meticulously dissect the cadavers for the next academic year. So he's doing something good for next year's first year.
And it's good for me as well.
Yeah.
It's an amazing opportunity. It's a real privilege. It's amazing learning. I've learned so much already. I'm going into my third. Yeah, so I'm really interested in surgery, so I didn't realise how useful that was going to be.
No, the fat has been removed, yeah. So basically, you first remove the skin and then you remove the fat, and then you have a small layer which covers the entire muscles. It's called the fascia. So it can have different names depending on how thick it is and how the structure differs. So you can have this, for example, looks like a tendon, it goes down, as it goes down, it looks like a fascia, but